Okay, ladies and gentlemen, we're going to get started. Everyone has busy schedules and some of our panelists have to leave. So with that, I'd ask you to end your conversations in the back and take your seats, please. Noise is a little disruptive to our live stream audience, so if you can please come and take your seats. And you want to listen to our amazing panel. This is really, truly an innovative discussion, making emerging markets work for development. We've been talking about that for many years. How do we make these markets work for development? How do we make these markets work specifically for global health? So people no longer have to die from preventable causes, specifically in the area of maternal, newborn, and child health. The speakers before us will address these issues. We have experts who are working on the global funding facility, and the facility is truly not even only an innovative approach, it's an innovative partnership. It's nothing like we've seen before, and it's taken off so quickly. This is really where we moved from conversation to action. And I think it's something where we begin to see the realities of the hard work that we've been doing over the past few years in looking at economically how we sustain these markets. So I'd like to start with Dr. Ariel Pablos-Menendez from USAID. I always ask our speakers to introduce ourselves to our live stream audience. We've been trending very high with the live stream audience from 42 different countries. So, Dr. Ariel.
Is this on?
And one of the main, questions that I'd like to begin with from our panelists is how do you see emerging markets working in this area over the next 5 years, especially with all the great work that you're doing in establishing the new global funding facility?
Well, thank you very much. There's been really a convergence that makes the time for the role of private sector and emerging markets converging with the work that we do in development. For many years, of course, the economics of many of those countries were not there in terms of the ability for markets to function, to be attractive, and beyond local and so on. But that's been changing, and in part is the result of success in the development enterprises in which many of us have been quite involved. Is only, in addition to the parallel developments in the larger economies and markets, in the health and development space, national health accounts that allow us to begin to measure resources is relatively new for developing countries. And so it's only in the last 10 to 20 years that we begin to get a picture and appreciate that half the health sector in Africa is private, that 60–80% of the health spending in South Asia is private. And that begins to open our minds to new ways of thinking. Public-private partnerships have been quite successful already in, say, the last decade or two in bringing a collaboration that was not very feasible ideologically or politically just a generation ago during the Cold War and so on. But that has opened minds and possibilities. And we now see, because of the economic success in many of these countries, the private sector coming to the fore. And the Business of Health in Africa report the IFC had just almost 10 years ago was very important in delineating those opportunities. The IFC held its meeting on health just last week in Prague, and likewise, we see many opportunities. I think that measuring those opportunities, the foreign direct investments in health, the expenditures in the private sector will give us macro opportunities for many of those who are investing in the space. But I think the business world has already seen this and is already engaging. And from a development perspective, as we see countries succeeding, half the countries that were low income in the year 2000 are now already in middle income status. And that graduation for us in the development enterprises is a great success story, and is driven by many good things, many good factors. But also it changes, or it calls for changes in the way we engage in that space. And in that sense, the economic success has been also accompanied by the great success in maternal and child health, with nearly 50% reduction in mortality, and the possibility that we can end preventable child and maternal death in a generation. And that's not a mere slogan, it's a well-modeled plan, but with a financial gap that will need to be addressed. And whereas in the year 2000 we had countries drowning in debt, in collapsing economies in Africa because of AIDS, that has changed. And whereas then a decade ago we called for debt relief and ODA, increased ODA, the conversation is changing in the post-2015 era towards domestic resource mobilization. And as we see the projections of economic growth, we can see that in many countries, they will take care of their own needs progressively, and that will bring opportunities for the private sector and for others. But from our perspective, we also want to make sure if we could only borrow from that future to save lives today. And it is in that sense, and we will hear from other panelists more details, that we see a great opportunity with the Global Financing Facility in mobilizing domestic resources through hybrid financing, but also leveraging these opportunities in results-based oriented investments to harness the power of private capital and partnerships in a creative way. I think in the post-2015, we'll see an explosion of creativity in financing engineering in the health and development space, and GFF is, I think, one of the first salvas of that great new possibility. So we'll hear more about that from our colleagues, but we very much look forward to not only working on government's resources through bank loans, but also working with the private sector in creative arrangements to foster sustainable solutions, and the markets tend to do that, as well as progress towards ending preventable child and maternal death. Thank you.
Thank you so much. And private sector has really grown, as some of our speakers said in the last panel. We're seeing a lot more developments of PPPs and a lot of more private initiatives that have started in terms of sustainable health development. I'd like to turn over the discussion to Mark from GAIN. I know that there's been a lot of PPPs, both that GAIN has implemented, but really in terms of financing in our discussion from not only an implementation perspective, but how funds like the GFF work with programs and PPPs that you've already been successfully doing in nutrition.
Great. Well, thank you. Thank you very much. I mean, I think first of all, we really do need to start talking about, what is some of this new financing and development paradigm going to look like, and I think we need to be very explicit about that. If you look at an area like nutrition, even right now, the gap in financing per year just to scale up the key interventions identified by the Lancet as most important is about $10–11 billion a year right now. And we're not the only sector where there is such a huge financing gap. And I think with the move to the Sustainable Development Goals, we're looking at an even bigger financing gap. I think the ODI in the UK is estimated for lower income countries will need at least, beyond what we can raise in taxes, we're going to need an additional $75 billion just for some of those countries. So we have the need, which I think is going up. At the same time, we have ODA, which Official Development Assistance, was kind of plateaued in 2010 and has been steadily dropping each year. Since then, with last year, the biggest drop of 16%. So we really do need to think of, well, what are these new models going to look like? We can all be hopeful that the Financing for Development Summit in this summer will come up with some great new model, and countries, developed countries are going to open up their wallets even more. But it seems unlikely given the fiscal situation and what we've seen each year. So we kind of have to start to think of, well, how are we going to bridge this gap? And I think a lot of it relates to, can we use markets much more effectively to deliver public goods? And I think that also speaks to using markets so that they reach our target populations. We know that certainly from the nutrition side, anywhere in Africa or the poorest countries, the rich are served as well as they are here in Switzerland. We're talking about using markets to reach the poor, who have low purchasing power, some of them who are barely in the market. And so how do we make those markets work much more effectively? How do we get investment so that market players are investing in the base of the pyramid? And I think more importantly, the whole question is, it has to be about scale. We really do need to have some vision towards scale. Not everything is scalable, but scale has to be a big part of the solution. I think when we're talking about malnutrition, where over 2 billion people suffer from micronutrient deficiencies, close to that number suffer from overweight, obesity. It go on. The figures are huge on stunting, whatever. So we need scalable solutions if we're going to do anything on nutrition. And I think some of those, some of the last 10 years, we have found some of those scalable solutions. I mean, and I think we shouldn't just try and reinvent everything. And we have, for example, the one that we've worked a lot in GAIN on is large-scale staple food fortification, which today reaches over 1 billion people, is driven by markets, and has some pretty good results in countries reducing key deficiencies, reducing birth defects, etc. It still needs to be scaled further, but this is one of these mechanisms where micronutrients are delivered through the marketplace, and most of the cost is shared by the government, the private sector, and the consumer, and they are fairly sustainable. But there are other models, I think, that are coming on stream, such as large companies leveraging much more effectively their supply chains. So we have a project, for example, with Unilever to in one of their big supply chains in India, to actually take on the providing access to nutrition for the farm workers in their supply chain. It's a win-win for them because it improves their productivity, and they cover a lot of the cost. So, and those supply chains, this is a small project for Unilever, but it'll reach about 3 million, close to 3 million farmers and their families. But we also need to look at what are some of these new base of the pyramid business models, because we have this challenge that we know how to deliver things we know how to give away things at the base of the pyramid, as long as we have a commodity or something to give away. But how can you? What are the business models? I think somebody mentioned it earlier in one of the panels. Is that we kind of have to find what are those business models, because a lot of it turns on those business models. Particularly, I mean, we heard an example earlier, if you're providing a weaning food or a complementary food to a woman who, for their child who only earns $3 a day, and you have to provide a quality product, there has to be some cost sharing in that model, and it has to be through the market. So we kind of have to look at what are some of those new types of business plans that reach the base of the pyramid and are sustainable. But some of those may be social businesses. We should not just be thinking of business as a multinational. I mean, a lot of the models that work at the base of the pyramid, the best case scenario is they break even. And so it has to have a social business model. At the top end of that market, you can make a high return. But when you're talking about the people we're most interested in reaching, particularly women and children, there is no fortune at the base of the pyramid certainly in the food sector. There isn't. The returns are so little. So what are those? So a lot more focus needs to be on those social businesses, but also, small, medium enterprise is very difficult to scale, but they are critical if you want to reach women in Africa, for example. Looking at in the SMEs in Africa, 95% of business in Africa are small, medium enterprises, and most of them, a large percentage, are led by women. So, yeah, it may be hard to scale, but you do need to invest in those and trying to come up with models that will support innovation from below, and trying to make that work. And something that we've done with USAID in about 4 countries is a marketplace for nutritious foods, which is really just supporting innovative models coming from below, which are providing food to poor people, But there are a lot of things that we wouldn't think of, selling chicken offals, things that everybody throws away in the chicken. Well, there's quite a market for those for poor people who have very limited money, and it provides high amounts of protein to the diet. But other models are things like self-help groups. We have a model rolling out in India, which is giving groups of 10 women a small production facility that can produce about 30 metric tons per month of a blended fortified food that goes into the public distribution system. Again, it provides a lot. Is it scalable? If you do enough of them, it's scalable, but on its own, it's not. But it does employ a lot of women, and it reaches children. So I think we have to start to be more creative in looking at the different kinds of models. And I think it comes a lot to, I think the new facilities like the GFF is great. I think it's using IDA money with other private money and leveraging that up. It does create more resources. There's the power of nutrition is another one that's modeled on the same type of approach. But I think we also need to look at changing the way development assistance works, and just not just thinking about commodity delivery. And one of the things that we found in Haiti was, we can keep sending from Europe ready-to-use therapeutic foods for severely malnourished people, and and they're very expensive. As long as there's a donor willing to pay for it, it can work. But by actually investing in a local company and through a loan with a philanthropic investment arm, we created a local supplier, who actually provides these for a fraction of the cost and will be there in the long run and have increased coverage quite a lot. Another model is where donors actually are co-investing on a one-to-one basis in innovative areas that relate to particular challenges around food security and nutrition. And I'll just end with this example. The Dutch government put up a fund of about 30 million euros, which is matched by companies to take forward risky investments or new investments. I think it's a bit what Peter Singer was talking about is, how do you, it's brokering and taking these forward, but you need some kind of mechanisms that will actually share the risk and the financing to take new innovations forward in the marketplace. And so changing the way we see development assistance much more is a big part of the solution. I'll stop there. Thanks.
Thank you so much. The World Bank and Norway, through the GFF, have created a new paradigm to make markets work for development. Why do we need a new paradigm? I pose that question to Dr. Tim Evans.
Okay, great. Thanks, Joanne, and apologies for being a little bit late. I was getting my health promotion exercise between the palais, which I think is a well-beaten path this week. So people should be logging with their Fitbits, their steps, and maximizing that. I think there's, it's always ambitious to talk about a new paradigm, but I think we're in the development community, we're realizing that, first of all, that we're in a very different place than we were 15 years ago. And 15 years ago, there had been a paradigm change insofar as large monies in global health went from millions to billions. And in the mid-1990s, if one had said that there would be $1 billion fund somewhere, people would have looked at you and said you have some form of DS4 diagnosis related to either schizophrenia or some other serious hallucinatory problem. And in fact, though, in the early 2000s, we had $1, $2, $3, $4 billion global efforts to really move forward on pressing health agendas. And so a very impressive mobilization, and I think there was an implicit assumption with that euphoria of moving from millions to billions that we had arrived. How could you think of needing more money? This obviously would do the trick, and impressively, we started to see results associated with that. Putting, 10 million people on antiretroviral treatment was probably thought not possible. It certainly was not thought possible in 2000, and even in 2003 when WHO announced 3 by 5, it was met mostly by skeptics who said impossible. Yet, although they may have been right in terms of the timing of achieving 3 million people on treatment by 2005, by 2007 the target had been met, and we're well beyond. So I think now what's happened is that we've realized that even with billions of dollars mobilized, that's still a drop in the bucket of the $7 to $8 trillion healthcare economy globally. And that when we look at the proportions of finance in countries, that there are 2 reflections, or 3. The first is that domestic resources are growing. Health economies are growing. That reflects the fact with positive growth, budgets grow, and if health maintains its proportion of the envelope, then there should be some incremental increase in the health budget associated with economic growth. In addition, though, we see growth in the private sector and private sector expenditure. And where we see most of that growth in low middle income countries is in out-of-pocket expenditures. And that's a worrying form of growth in health expenditure because it's often associated with impoverishment, and as a reflection of the system where if money is what you need to access the system when you're sick, many people just don't go. And so that's a worrying form of growth. And then the third part of this is that, well, what is the connection between development assistance and the growth of the overall health system? And what we've seen there is there's a tendency towards substitution as opposed to additionality, meaning more development finance is not associated with more domestic resource mobilization from particularly public sector, but often a substitution whereby there's a decrease in public commitments. And that's not something which sits well in terms of a longer-term thinking of financing for development. So with those reflections that the billions are great but not sufficient, that healthcare economies are growing but perhaps not on the right track, and that we've got to forge a stronger linkage between what we do in development finance and how we think about the long-term financing of the countries that we're interested in supporting. I think we have the 3 ingredients for a paradigm change. And that paradigm change is one where we have to much more conscientiously think about how development finance is really supporting the emergence of a capability in country for fair and sufficient financing of health systems as they move forward. This is more pressing, not simply because we have a financing for development meeting in Addis. It's more pressing because many countries are transitioning from low-income status to low-middle income to middle income. And with that transition, one needs to look at how one can really begin to prepare countries for a situation where grant financing will no longer be available. And in that context, it's not simply public sector financing that we need to be catalyzing, it's also private sector financing. Now, private sector financing comes from multiple different sources. And I think the entry points for that are ones that we can also be much more explicit about. coming from people's pockets at the point of time when they're sick is really not something we want to promote. That's bad private sector financing. Good private sector financing is looking at companies that can manage medical equipment more effectively to keep it high performing in facilities than it is currently at the moment. Private sector activity that we might want to encourage looks at how we can scale up the training system so that the workforce can be much more not only robust in quantitative terms, but also appropriately in terms of the different cadres that are needed to manage delivery of resources to various parts of the health system. So those are the sorts of, I think, private sector entry points which involve market mechanisms, which we need to look at much more explicitly and embrace as part of the overall financing of the health system moving forward. Thank you.
Thank you so much. I think the private sector integration points are so key, and I think in terms of the partners around the table, USAID has done a lot in terms of the private sector mobilization for maternal, newborn, and child health, and that has been key to quickly, rapidly escalating some of these interventions to get to the women and children that need them on the ground. With that, I'd like to turn to Tori in terms of a lot of the work that's been done both from Every Woman, Every Child and now, the GFF. How are these different, initiatives both going to create the new paradigm that Tim discussed and take us into an emerging market where we will eventually have sustainable development?
Thank you very much. It's on. I will give you some concrete examples to try to answer your question. So if you take a country like Ethiopia, it has had a tripling of its GNI per capita from 2000 during the last decade, and it will triple again at least up to 2025 and will become a middle-income country. So the question is then, what can we do now that would actually facilitate the Ethiopian market and the uptake of new technologies in particular? And that, so there we have now experience, and the most recent we have been involved in is the implants for family planning, where then we could make a deal with the company that are producing these implants, that if we guaranteed a volume, a large volume of actually 270 implants, 270 million implants, then they were prepared to halve the price. And so market shaping globally from that point of view is a very important then kind of front loading the system or pumping the system now so that it becomes a sustainable market in the future. Another example is, and it's relating to what Gain talked about, is local market shaping. And here we have been working with the Clinton Health Access Initiative, and this is becoming a very important part of the global financing facility. That is to take a simple product like oral rehydration salts, and many of the products we are dealing with in terms of family planning, maternal, neonatal, child and adolescent health is actually simple solutions that are locally produced and the market is oversaturated. Then they facilitated then to actually divide the market in three for three producers that would meet some specifications and improve the product both in terms of color and taste, add zinc, and at the same time was able to achieve a substantial reduction in terms of the product. And it's all then based on local market shaping. In some instances, as gains indicate, there is then an opportunity for investment in order to make the quality changes in the production that would be required. And a second example here of a public-private partnership is the Association of Mobile Operators, which GFF will support, and they have agreed to actually provide mHealth services virtually free of charge. And the business model is their experience from agriculture, where when they did a similar thing in agriculture, they saw that there was a very substantial increased use of mobile telephones, so they are getting their income back through that mechanism. So this is a sustainable business model. Finally, you may ask Norway why we are investing then in this, and the Norwegian government decided to invest in the global financing facility because it is tailor-made for the post-2015 agenda, in a sense that it is exactly doing as Ariel and Tim has indicated. It is the smartest way, smartest thing on the block for making aid catalytic. So that was one very important aspect, and through diversification of resources. And the other reason is that it is results focused and results based, and that is another paradigm shift that we are seeing in aid, is to rather than look at inputs, is looking at outputs and outcomes. And the GFF then combines those two, which makes it extremely attractive to as a vehicle for aid to then front load now the markets that will then be sustainable in the future. Thank you.
Thank you so much. Due to time, I know some of our speakers need to leave. We usually would break out into discussion clusters, but we are going to have two questions from our discussion leaders to the panel before they leave. And so I'd like to introduce David, Chief Medical Officer of the GE Foundation.
Thanks, Joanne. So I had a couple of comments and then followed by a question for the panel. My observations this morning are that the private sector obviously has a tremendous role to play. As many have commented on, we've reached sort of the tipping point of where the private sector can play in global health development and global health security. And there are lots of areas around product development, I think around education and workforce development, in financing and creative models for financing. And the last one, which I didn't hear talked about, but I'd love to get your input on, is the idea of experimentation or piloting. And thinking for the private sector and for the global health community to start thinking more about, should we just, instead of having conversations, like Joanne said, begin to act and begin to act quickly and come up with an idea, experiment on it, pilot it, measure it as someone said earlier today, and then go forward and scale the things that we see are working. And how can the private sector work with global health leaders to begin to do some of that more effective, quick experimentation and begin to scale those things that work?
Well, thank you very much. USAID invests about $200 million already in what we consider classical PPPs, public-private partnerships that evolved 10, 20 years ago in the R&D space, and the harness philanthropic and government resources to work through intermediaries with academia and corporate sector to develop a solution. And, but you're right, there's the space for creativity is far bigger than that. And in recent years in particular, USAID has been developing more and more instruments for investments, not only working directly with small businesses to deliver traditional development assistance, but also developing new instruments in government. For us is how we do the awards is a big machinery issue. And, but we, from global development agreements to opportunities for market shaping as described by Torre, where we have been partners, to opportunities for market guarantees, to loan guarantees, all sort of instruments that may allow us to experiment. And we have now developed all of that into a financing framework for us to harness private capital and collaboration for our purposes in developing assistance to the poor to prevent social material debt. And this is something that we are aligning with the GFF to bring all sort of instruments that we are going to be deploying through our mission. So we certainly hope and look forward to engage with you and others on very specific solutions in specific countries and settings, because we see a richness of opportunity, and we are now gearing up with the instruments to do so.
Thank you. Other panel?
I would, if you look at where aid's comparative advantage is, I think it is a very important area is innovation, and that would include experimentation. So in Norway, we have with about 10% of our aid so far is on relating to innovation and research and development, and I would guess that that proportion will increase in the future. The major current financial mechanisms do not have a sufficient opportunity in this regard, I think. And so this is something that is very important to maintain and to get an increased focus on in the future. And we can see from the Ebola outbreak how important it will be to have good tools that can help to both products that can help us combat pathogens that have the potential to become regional or global pandemics, as well as tools that will strengthen then the ability of the health systems to act rapidly in that context.
Thank you.
Yeah, I think it's a great question. And, you know, I think we all want to avoid the situation that, you know, the Ministry of Health in Uganda faced a number of years ago with a new ICD code called pilotitis. And this was this litter of very small, overlapping sort of efforts to do communication through mobile devices to different populations. And I think the ministry said it is like, we don't know how it adds up. And so I think some of the conditions for scale need to be thought about very, very clearly. And it will benefit from investments in global public goods. So often a regulatory regime or common standards or for digital platforms in the context of electronic records, or common standards for interoperability, those can help provide a platform upon which the private sector can grow to scale much more effectively. And so it's actually takes a little bit of an investment, but it actually opens up the economy in a much more significant way to the full scale opportunity. So I think that's one thing to look at. The second is that is to really recognize increasingly that that the market characteristics of health systems are not confined by national borders. And I think that is going to be a growing reality, and very helpful in understanding some scale opportunities. So And so if you look at specific parts of the market, I mean, we all know the pharmaceutical industry is very rarely bound by national borders. That doesn't mean that there isn't an important participation at the national level from all sorts of different parts of that, the value chain of the pharmaceutical world. But the issue related to scale efficiencies in production, costs of manufacturing, pool procurement opportunities, I think these are things that we need to keep our eyes open to, which might help us get to scale a little faster. Thanks.
Thank you so much. I know some of our panelists need to leave, so I welcome you to continue this discussion, and we will be continuing the dialogue in the coming months. I know also there's a measurement summit in a couple of weeks now, just 2 weeks away. So, some of you around the room, especially private sector CEOs, it's important in terms of the previous discussion and this discussion to really look at measurements and outcomes. So the measurement summit is June 6th through 8th in...
It's 9 to 11 June in Washington with the World Bank WHO. And thank you for making that note. Health has been relatively successful in measurement compared to other sectors in development historically, and that has contributed to the success. I can tell you because in Congress, we tend to do better than those who work in some other sectors because of measurement. And as we enter post-2015, we want to have new paradigms for measurement, and private sector will be very important in not only bringing solutions, but also in the sector itself, what role they play. And this will contribute to a new roadmap for measurement results and accountability that will be brought into the World Health Assembly a year from now.
Thank you so much. So we welcome seeing you there in a couple of weeks. With this, we're going to rotate panels, and there'll be no break so that we can start right away. Thank you. Thank you to our panelists, because I know your schedules are very busy.